Good afternoon, everyone. Welcome to the latest session in CADIF's COVID-19 webinar series. I'm Gino DeAngelis, Manager of Clinical Research at CADIF. I'm currently helping oversee CADIF's condition level review project on long COVID, so watch for this later this fall. I'm moderating today's webinar from Ottawa, Ontario, Canada, which is on the traditional unceded territory of the Algonquin Anishinaabe people. Since time immemorial, the Algonquins have been the keepers and defenders of this land. I recognize and deeply appreciate their historic connection to this land, and I want to thank them for their generations of stewardship. I'd like to encourage everyone joining us today to think about where you live and work and give thanks to the people who lived there before you and cared and sustained for this land. COVID-19 was declared a pandemic by the World Health Organization on March 11, 2020. Within a few months, the term long COVID was being used initially by patients to describe a longer, more complex course of illness some people were experiencing. Long COVID now has more clinical names, such as post-COVID-19 syndrome, post-acute sequelae of COVID-19, and chronic COVID syndrome. Whatever the name, it refers to the persistence or emergence of symptoms weeks or months after someone is infected with COVID-19. Long COVID has major implications for the delivery of healthcare services. Some research believe that the number of long-haul COVID patients could be as high as 30%. Given those numbers, pressure will only increase on hospitals and health systems already stretched to the limit by the pandemic. I'm honored to be joined today by three clinicians who are researching long COVID and treating long-haul COVID patients. They're here to answer your questions about long COVID, including but not limited to how it's defined, what's being done in terms of treatment and research, and what needs to be done going forward. Let me introduce our experts from west to east. Dr. Jesse Greiner is a general internal medicine specialist at St. Paul's Hospital in Vancouver, British Columbia, Canada. He's the medical director of the Provincial Interdisciplinary Clinical Care Network's first post-COVID-19 recovery clinic. Dr. Angela Chung is a professor of medicine at the University of Toronto and senior scientist at the University Health Network. She's also the co-lead of CanCove, a Canadian COVID-19 prospective cohort study. And rounding out the panel is Dr. Amelia Liana Falcone, the director of the Montreal Clinical Research Institute's post-COVID-19 research clinic. She's also the director of the Institute's Microbiome and Mucosal Defenses Research Unit and a professor in the Department of Medicine at the Université de Montréal. In terms of the format, we decided to forego formal presentations for this session and jump straight into the question and answer period. You can submit your questions at any time by clicking on the Q&A tab in the Zoom control bar. Please let me know if you want to direct your questions to a specific person. While you get your questions ready, I'll get the ball rolling by asking each speaker a couple of questions. I've also encouraged our experts to ask each other questions if they want more detail on anything that comes up. So let's start with Dr. Angela Chung. Dr. Chung, can you give us a quick overview of the clinical and research work you were doing related to COVID-19 and long COVID in particular?
Sure, and thank you, Gino, for inviting me to this panel. Since March of 2020, we have been looking after post-COVID condition in our general internal medicine clinic. And I'm also leading a Canada-wide research study called CanCove. It's the Canadian COVID-19 prospective cohort study. This study, the aim is to really look at the short and long-term outcomes of patients who have had COVID and really look across the severity of illness spectrum. So we are recruiting patients who are non-hospitalized, those who have been hospitalized in the acute care ward, as well as those who were admitted to the ICU. And currently we have about 1,700 participants, and they are from Vancouver, Winnipeg, Calgary, Montreal and Sherbrooke in Quebec, and multiple centers in Ontario, including Hamilton, Niagara area, Brampton, and obviously the Greater Toronto area. We're learning a lot through the patients who are participating in this study, and have to really emphasize that it's really a partnership with patients as we sort of try to understand the evolving science. We are also running a couple of newer studies, hope to launch in the next little while. One of them is called Reclaim, Recovering from COVID-19 Lingering Symptoms, Adaptive Integrative Medicine Trial. And so this study is really trying to look at interventions that may actually shorten the post-COVID condition.
Thanks, that sounds very interesting. So last week, the World Health Organization released a formal clinical definition of long COVID, which says post-COVID-19 condition occurs in individuals with a history of probable or confirmed SARS-CoV-2 infection, usually 3 months from the onset of COVID-19, with symptoms that last for at least 2 months and cannot be explained by an alternative diagnosis. Does that capture the essence of long COVID? And is there anything that you would add or highlight in this definition, Dr. Chung?
This is a step forward. We actually have a definition, and that the definition is not only confined to those who have confirmed SARS-CoV-2 infection, but also include those who have a history of probable SARS-CoV-2 infection. Because as you remember, in the early days of the pandemic, we have limited resources, and many of our patients were not tested. They were just asked to isolate at home. And so this definition includes the group that were never tested positive with a nasal swab PCR test. I think using the 3 months cutoff is a good one, because you can see the spectrum. Yes, if you have like the flu, you expect to be, may not be well for a few weeks, but you don't usually expect to be unwell at the 3-month time point. But if you were in the ICU for 2 months, well, you may still have symptoms at the 2 or 3 month time point. So I think having a cutoff of 3 months is a good idea. I think the prolonged piece, meaning having symptoms for at least 2 months, is also a good sort of definition for post-COVID condition. I think what is not captured in what you just mentioned is the episodic nature of it. So some people will feel better and then they go back to work. Because of the physical, cognitive, and emotional load, they may have relapses, or what we call post-exertional malaise. And when they get relapses, so they may feel better and then they may relapse. And so the episodic nature is important in this post-COVID condition as well.
Great. And what can you tell us about the risk factors for long COVID? This is something that's been brought up and asked quite a bit as we've been researching it, but what can you tell us about the risk factors for long COVID?
I think those who have more severe illness at the beginning may have a higher risk of having long COVID. Now, there are really a couple of issues that are overlapping though. So like if you were so sick in the ICU that people do all sorts of things to you to keep you alive, those treatments and interventions can also cause fatigue and other issues after you recover. And so we have to separate the post-ICU syndrome from the post-COVID condition. But if you look at non-hospitalized patients, those who have more symptoms in the first week, and there've been a couple of studies out now looking at 5 or more symptoms, then you have a higher risk of having COVID condition. The other risk factor is being female. If you are a woman, you have a higher chance of having long COVID than if you were a man. And so, that also may be the nature that in terms of those who are hospitalized, we actually have more men than women as well. So women tend to get it slightly less severe, but they can have more prolonged symptoms.
And then focusing on Canada here, do we know how many people are affected by long COVID in Canada? And if not, how can we measure prevalence?
That's a great question. I think a bunch of us have been trying to look at this. So Canada has had 1.6 million people affected by COVID, at least. These are the confirmed cases. And if we take a 10% cutoff, then it would be greater than 160,000 people who have currently or have had post-COVID condition. My guess is that it's higher than that. So I was working with PHAC, the Public Health Agency of Canada, on a living systematic review looking at the prevalence and also symptoms of long COVID. The problem is that the studies are all over the place. Some study will say if you have one remaining symptom, you have post-COVID condition. And some will say, well, if you have 5, you have post-COVID condition. And so the range of prevalence is quite wide, from anywhere, from the lowish of 10% all the way up to 50%. And I personally, I feel that the truth is probably somewhere in between. So we can have as many as up to 500 patients in Canada with this condition. The issue is how severe it is. Is it just mild and you can use a nasal inhaler and deal with it and still go to work? Or is it more severe that affects your life and you can't even get up out of bed to take a shower, for example? And so I think there's a lot of heterogeneity in the severity of the post-COVID condition. So it is really hard. But I think there are some things that may be helpful to look at as we go forward. For example, last week, ICD-10, so this is the coding, actually has a post-COVID condition code. And so prior to all of this, clinicians can't really put post-COVID condition. They can just put COVID-19 as the diagnosis. And so with the post-COVID condition ICD-10 code, we can use administrative database across Canada to take a look and see how many people are seeking care for post-COVID condition. And so, we can't tell right now, but hopefully in half a year, we maybe have a better idea.
That's great. Yeah, it certainly sounds very challenging to measure, but we are making progress, so it's great to hear. Dr. Chung, thank you very much. I will be back with more questions later in the session. I'm already seeing the questions pour in, so that's excellent to see. Next, I have some introductory questions for you, Dr. Grainer. So you're the medical director for the first post-COVID-19 recovery clinic in British Columbia. Can you tell us a bit more about that experience?
Yeah, sure. First of all, I guess thanks for inviting me to be a member of this panel as well. I feel really grateful to have this opportunity to share what we've learned with the country. The work in the post-COVID condition has been, I'll say, exceptionally challenging. The real challenge from my standpoint is, as physicians, we all go to med school and learn for 5 to 9 years about how to manage medical illnesses, right? So that when we see patients in the office, we know what to do with them. And then we didn't have that opportunity with COVID-19, right? So I literally had to go and sit in an office with a patient and say, I don't know what I'm doing, but I'm willing to help you and listen and try and explore what's going on and work with these patients. And so the first, year of this journey was a lot of learning from the patients as much as they were learning from me, so that I can then take that information and feed it forward, and we can sort of pivot and adapt the work that we're doing here in the clinic to try to optimize the outcomes down the road. So it was really challenging just from a clinical standpoint to sort of meet the needs of these patients. Operationally, it's been another headache because of the sort of episodic nature of the disease. It's difficult to predict the flow of patients through the clinic and to build resources around these patients to identify, the number of nurses that you need, the number of OTs and PTs and physiatry appointments, to do any of that sort of predictive work to sort of make sure that you're meeting the demand for the patients has been exceptionally challenging because the numbers of COVID patients is just sort of episodic like this, and it's difficult to predict. So that's been sort of the main experience, the main headaches that I've had in running these clinics. Yeah.
Thanks for sharing that. That's quite interesting to hear, and especially for that perspective as well. The next question I have is something that I've heard quite often as well, and it's how is long COVID being treated, and how effective are the clinical interventions specifically for identifying, preventing, and managing this condition?
Sure. I think I'll start by saying I don't actually diagnose people with long COVID per se. I don't diagnose them with PASC or anything else because I actually don't find it to be that helpful in terms of like pushing people down the treatment sort of protocols. It's kind of like I use the analogy of it's like I diagnose somebody with heart failure, and if I tell an internist that somebody has heart failure, that doesn't mean a lot, right? And there's so many different ways to manage heart failure, whether there's a problem with a valve, or a problem with an arrhythmia, or a problem with ischemia, a problem with long-standing hypertension. All of those have very different treatment algorithms, and that the true is really the same for this post-acute sequelae of COVID-19. And so Angela alluded to this a little bit, that there's an incredible variance in terms of the presentations of patients to this clinic. So on the extreme end of things, there's a whole bunch of people that have really severe acute illnesses. They have sort of acute comorbidities. They'll have, the myopericarditis. They'll have significant pulmonary interstitial lung disease and pulmonary fibrosis and organizing pneumonia. There's people that have blood clots. And so each of these specific medical things will be treated sort of in its own right. And this is why I think it's actually so lovely that this COVID condition has been nested in the internal medicine universe, at least at our site here in Vancouver, because we have the capacity to sort of branch out and direct patients to the expert care that they require for each of these specific comorbidities. So all that being said, I really take a biopsychosocial approach to managing these patients, and I think that's probably the optimal approach. So under the sort of biological sphere, that's what I've been talking about, right? Managing each of the biological complications that these patients have, screening for comorbidities, screening for problems, and that's a lot of the work that we do here in the clinic. But the other part is like equally as important. So the psychological and the social, emotional aspect of this disease, I think, is equally as important. And there's a whole host of patients that have these episodic symptoms that Angela was talking about, that they don't have any of these sort of organic things that we can tangibly sink our teeth into in terms of making a clear diagnosis or like having an organic treatment plan. And so that doesn't mean that their symptoms, it often means that patients struggle to get adequate recognition from care providers for these symptoms. They will often get sort of looped in as anxiety or other mental health conditions. But when you look at these symptoms, there really is like a very narrow illness script, right? And Angela was talking about post-exertional malaise or post-exertional flaring of the symptoms. To be honest, I see post-exertional everything, right? Post-exertional headaches, post-exertional dizziness, post-exertional numbness in your big toe, post-exertional chest pain, like it's all post-exertional. And so to me, the management really is around like plan, pace, and prioritize, and patient education. So it's helping patients understand what their illness is. And a lot of patients struggle specifically with the fact that there's a delay often between the trigger and the flare in their symptoms. And so helping patients sort of see and understand that relationship between the physical, cognitive, and emotional stressors and the trigger in their symptoms is the one thing that I feel like makes a fundamental improvement or difference in the long-term trajectory of this illness, and what keeps me motivated to like keep working as hard as I can. So to me, that one thing, that patient education, teaching them the relationship between the stresses that they're experiencing and their illness is the one thing that like fundamentally makes a big difference. And then there's like all the supportive care that I wrap around that, right? So a lot of pre-existing conditions get exacerbated by this condition. So a lot of chronic pain, a lot of insomnia, anybody with mental health conditions, a lot of those things can sort of feed into this, right? You can see if people have social or psychosocial stress as a trigger for their symptoms. If you have a background of anxiety, that's going to be a really complicated confounding variable. So we try to navigate and help support patients with all of those pre-existing conditions as well to help optimize their outcome. In summary, I actually am like very optimistic about the long COVID condition. I think in the clinic, I see an exponentially decreasing symptom burden in the patients that are able to see and understand this connection, and the patients that are able to sort of bring that level of stress, whatever it is below the threshold that's triggering their symptoms, they have good outcomes, right? It takes a long time, but they do like almost invariably slowly get better. And I'm sure that each of the panelists up here have patients that like jump to their mind that like, no, they didn't get better. Or there's like these people that have ongoing symptoms for long periods of time. And I've certainly seen a lot of those patients that, you know, don't get to the COVID clinic for a year or so, and they continue to have ongoing debilitating symptoms that where they're unable to work. But usually once we're able to wrap them around this education and plan, pace, prioritize sort of dogma, they do start to see some significant improvements, albeit slowly. So I'm very optimistic about the success of our treatment plans here.
I think the optimism is definitely great to hear and music to a lot of people's ears. And I'm also glad that you brought up a lot of the chronic conditions, because I'm noticing some of the questions coming in are asking just about that and the chronic conditions associated with long COVID. So thanks for touching on that. The next question I have is probably of interest to the research community. And we are wondering, are you gathering real world evidence on long COVID at the recovery clinic?
Yeah, so there's we've sort of set up the system. So there's two sort of tiers of people that are working in the COVID network here in British Columbia. There is a research group and an administrative group that's running the whole clinics. That's led by Dr. Adir Levin here at Providence. And my role really is in managing the clinical stuff here at St. Paul's. So what I can tell you is that when the clinics were set up, the whole idea was that you would systematically collect information in an objective way so that you can basically create a pool of data or information that you can then use to sort of test hypotheses and ask and try to answer some of these questions as they come up. So every patient that comes in gets seen at a standardized test interval at 3, 6, 12, and 18 months, unless they're like, we've just recently said that if patients are doing well, we can discharge them from the clinic. So they're seen at a standardized interval. They get standardized screening blood work to look for the medical complications, those biologic complications I talked about, and they get sort of a 9-page questionnaire that really is a lot of patient-reported outcome measures. There's like a UCSD-9 shortness of breath questionnaire. There's like a GAD-2, a PHQ-2. There's a whole bunch of psych screening. There's a quality of life. There's a EQ5D5L in there. There's a whole bunch of data that's collected in a rigorous standardized fashion. And at the beginning of the pandemic, we were doing standardized echocardiograms and CT scans and pulmonary function tests in a lot of patients. And we sort of backed off doing a lot of that, recognizing that we were getting a lot of normal studies in a big subset of patients. So it really is the questionnaire information and a lot of the screening blood work that we're collecting in a standardized way, and is sort of just sitting in this pool waiting for researchers to sort of dig their teeth into.
That's great. Thank you, Dr. Grainer. Again, we'll return to some other questions afterwards. So our final panelist, Dr. Emilia Liana Falcone. Based on your current work, what are the biggest challenges in long COVID research?
Hi, Gino. Thank you for this introduction, for including me in the panel. So I will begin by just giving a perspective of what our experience is at the Montreal Clinical Research Institute. So our mission and our angle with our research clinic is really to get at mechanism underlying the post-COVID condition in order to identify new therapeutic targets and diagnostic biomarkers. So within that optic, our goal is perhaps to see slightly less volume of patients, that is under 1,000, but in a more granular way in order to systematically collect clinical data, molecular data, and to biobank patient samples. So every patient who comes to our research clinic is enrolled in a protocol. And within that protocol, they are clinically evaluated. They are seen by a clinician. And there are a set of standardized tests that are being performed, which also include questionnaires, clinical testing, blood works, physiological tests, some of which were already mentioned, like pulmonary function testing and echocardiograms, as well as tests that are much more in the realm of research, which include things like looking at broad panels of autoantibodies, inflammatory markers that go beyond those that we see clinically, and of course the microbiome, given my research interests that stem pre-pandemic. So this is a little bit our optic going into the realm of the post-COVID condition. And with this perspective, what I see as some of the biggest challenges right now, I would say first begin with a classic issue, I would say in a lot of studies, is to have better representation of the general population. I think we can all say that we need to do a better job at outreaching into communities that are typically underrepresented, not just in terms of access to clinical care, but also in research studies. And this is for a variety of reasons. So we need to reach out to racialized communities, indigenous populations, individuals of different socioeconomic backgrounds. And in that setting, these are individuals who might not have the possibility to even participate in studies because they are time consuming, they take away from work, etc. And I think getting more now into the scientific aspect, we need to capture individuals from different waves of the pandemic. And like Angela mentioned, this includes individuals who don't have a molecular diagnosis, and that's tricky. But it tells us important information of, again, from a scientific perspective, as well as from a clinical perspective, what was the impact of the virus and the variant that was present at that time, and how it's evolved now that we see a lot of Delta in the fourth wave. So there's several reasons why we want to include even patients who don't have a molecular diagnosis. Building on that is an issue with the inclusion of proper control groups. And this isn't always easy to do in long COVID research, as we've all experienced. Yes, we need the age and sex matched controls. And ideally, we'd like them for the hospitalized cohorts to have hospitalized patients that were hospitalized for a reason that didn't have anything to do with COVID, but that's not so different that we can't use them as comparison groups. We also want those age and sex matched individuals that were not hospitalized and did not get COVID. So this is our, it could be our healthy control or a disease control group. And especially in long COVID, depending on the question we're asking, we want to also evaluate individuals who had COVID but never developed long-term sequelae, or at least no symptoms past 4 weeks. This, leads to ultimately, the fundamental issue of avoiding selection bias and referral bias, which is something that's plagued a lot of the smaller cohort studies that have come out earlier on as we began to learn about the post-COVID condition. And I'll say, like, just in our research clinic, the overwhelming majority of patients that are seen are self-referred, and they were not hospitalized during the acute phase of their infection. And there's a lot of need, obviously, because they didn't, in some cases, because they weren't hospitalized, they didn't benefit from some of that follow-up that occurs when a patient is discharged from the hospital. The next is the need for a standard definition and a standard CRF. So we're getting at the standard definition. I think this week we got great news, which is wonderful. And there is a standard CRF that was issued by the WHO. And I think here it comes at, we're speaking to a collaborative effort that needs to take place where we start to harmonize some of these different research efforts and start to collect data in a similar way using the same definitions. And in that sense, we need to keep on fostering pan-Canadian collaborations. I think this is where we need to start. And so if you didn't witness the dialogue that was going on off camera before this webinar, but some of these collaborations have already begun to be discussed, and I think that's very, very exciting. Another aspect that I think would help us in terms of being more efficient and maximize the data we have at our hand is ways of better using electronic medical records and using the data that can come out of that, of course, in an ethical way, which is not always obvious. And of course, across provinces, we have different ways of assessing electronic medical records, or even implementing electronic medical records for that matter. But this is something that is, I would say, in some countries is better optimized, and the information is better utilized to guide a more broader way clinical management, but also to be able to anticipate what some of the long-term effects and long-term needs are going to be on the healthcare system because of the burden of the long COVID condition or the post-COVID condition. So that's my my summary.
Thank you for that. I'm wondering if you can speak a bit more to your observations of the specific long COVID symptoms and their evolution over time, thinking about your specific research clinic and your cohort study, if you can speak to that a bit.
Yes, so as Angela and Jesse have already mentioned, the patient who was hospitalized in the acute phase will have a different evolution in the post-COVID phase. And a lot of that is a lot more tricky to demystify in terms of what were the comorbidities going into the acute infection. And because of the exuberant inflammatory response, the chances are there was much more end organ damage that was done. And now what we could be seeing are the sequelae of this damage. And this is under a background of what already is incurred in terms of deconditioning and long-term effects of a hospitalization, especially in the ICU. So that is, these are patients that sort of follow their own evolution, and some of, depending on the end organ that's affected, the course could be very long-term, and in some cases may be irreversible, depending again on what complication we're talking about. Now, if we look at the non-hospitalized population, which is what we really see more of, what we've begun to see and what has been observed in some other studies, as especially one of the more recent patient-led initiative study that is really, really very interesting. We see these sort of clusters, in a sense, of patient symptoms that emerge and that have a sort of different evolution. And I would love to hear, what has been the observation from Angela and Jesse with their experience. But what we've seen is, for example, we have some patients that will have more of a shortness of breath and a chest pain syndrome. We've eliminated any objective end organ complication in the sense that to the capacity of our current tools of evaluation, the tests come back normal for all intensive purposes. And those patients often, especially if they get some rehabilitation, we've noticed that by the 6 to 8 month time point, there's a significant improvement. But there are other patients, we've seen a cluster of patients who have more of the olfactory or gustatory dysfunction symptoms and sometimes have no other condition. And some of those patients can have this really, these problems going on for a very long time. And we've seen them now beyond 1 year have issues regaining their sense of smell and taste. Then there's that subgroup of patients that they seem to be evolving more into a phenotype that's consistent with a chronic fatigue syndrome, and they're really displaying, now that we have a little bit more retrospective vision because we've seen patients beyond 6 months post-COVID, we can start to really see that emerge, where patients are chronically fatigued, they have the post-exertional malaise, and they have some of the other characteristics of chronic fatigue syndrome. And a lot of that management is consistent with the management that Jesse's described and that he seems to really have integrated into his practice. So this is sort of, what we're seeing, and I think as more studies come out, I suspect that some of these clusters with different evolutions will emerge.
Maybe just open it up to Dr. Grainer or Dr. Chung. Was there anything you wanted to add in terms of symptoms for long COVID?
So there are many, as you have seen, like more than 100 symptoms have been reported. And I think what I agree with Dr. Falcone and Dr. Grainer's sort of description of how patients do over time. One of the common things that we do see is a lot of executive function, attention, and short-term memory issues. Commonly called brain fog. I think the neurological part is something that we see probably more so than other post-viral conditions. The other thing is for those who have had, smell and taste problem, I always tell them, I have talked to the rehab folks in terms of how we can help you, but I don't have a solution. Because the rehabilitation for smell and taste is really trying different smells. And so when they start saying, oh, you know what, it's not totally gone now. And now I have, I smell a certain smell. Like one patient of mine said, everything smells like chicken noodle soup. And another patient said, everything smells like, stale coffee. That person actually had to change their coffee so that they can tolerate it. And when that happens, that the nerves are connecting and that it's really part of the healing process. And so when you tell them that, they're not so scared that, oh my gosh, what's happening? And we do see improvement over time.
Yeah, one of the analogies that we use about that in the clinic, because it's sort of sporadic, right? Different neurons will start to regenerate at different rates, and each one is representing a different aspect of the spectrum that is smell and taste. I'll often say that it's like trying to play a song on the piano, but you're missing some keys. So you're definitely not going to get an adequate perception of what's going on. But the fact that it's kind of starting to come back is very encouraging.
And often the resting and pacing is important as well. So resting and pacing yourself will keep everything under the threshold, as Jessie was saying, so that they don't have flares of whatever is bugging them, whether it's brain fog or headaches or their toe hurting or whatever it is. So the resting and pacing piece is important. I find doing breathing exercises important as well. And that may have two kind of effects. One is to strengthen the breathing muscles. Another one is really to modulate your autonomic system by breathing, slow, deep breaths in and out. So I get patients to do those two things.
I guess I'll just jump in quickly as well and say, I too, Amelia, have noticed the sort of clusters of different symptoms, the like sort of chest pain, shortness of breathy people, the headache, dizziness, fatigue, brain foggy people, the anosmia people. I often describe them as like phantom smells on their way to like recovery. So people will often smell like gasoline and weird things. But I was doing a lot of like just thinking about this in sort of a broader context of other illnesses, right? So I talk about reference class forecasting and like trying to find connections between other conditions that we have known about for a long time, right? And so in a presentation I was giving recently, I was comparing the post-COVID-19 condition with the post-ICU syndrome, with myalgic encephalitis, with just straight up anxiety and depression, and with these post-concussion syndrome, and then with burnout. And you can line them all up and the symptoms are the same, right? It's impaired sleep, fatigue, dizziness, reduced working memory, reduced concentration and attention, increased pain, depression, anxiety, like all these things are like exactly the same amongst all of these conditions. And they all share like a fairly similar phenotype, right? I can't explain to you why somebody it's chest pain and somebody it's shortness of breath and somebody it's brain fog and headaches, but it's fascinating to me that the syndrome, like the pattern is the same in all of these conditions. And I think what all of these have in common is there's some sort of insult to the body. And so we see models in lots of physiology from around the medical literature in terms of, like, if you think about orthopedics, the sort of stress strain graph, the elastic region, and then there's the plastic region where you just start to see strain at certain high stress thresholds. The same is true in muscles, looking at the stress strain relationships of ligaments and tendons and muscles. And it's the same when you look at cerebral autoregulation of cerebral blood flow. It's the same in the Frank-Starling curve. So all around, there's these ideas of stress strain, and I'm starting to think about this concept in that sort of dogma, that like there will be a threshold of stress that the body can handle without sort of straining or without deforming to sort of cause these symptoms. And whether that pathology is sort of in the brain or in the nervous system or in the endocrine system or in like the mitochondria of the muscles, there's like compelling evidence in all of those. But I'm still unsure where it's actually coming from. So it's just kind of an interesting way that I've been sort of starting to conceptualize and think about this whole syndrome of patients.
And it may not be from one particular thing. I actually think it is a multi areas in terms of the problem.
Absolutely. It just speaks to the interconnectedness of several aspects. And, we know that if we're not sleeping well, our moods are going to be impaired. We're going to have more pain. This is, of course, this just will just exacerbate any end organ damage that has occurred, whether we can detect it or not. So certainly, this is not a simple condition.
So Dr. Falcone, I want to go back and, thinking again about research. Can you kind of summarize what's the role of individuals with both lived and living experiences and other knowledge users, specifically in long COVID research? If you could just touch on that a bit.
I think it's huge, and I'm saying this from a person who I know half the time I spend working on in vivo and in vitro models in a lab. I have never appreciated so much the contribution of the patient and the patient partner as I have now, because we are learning about this disease or this condition at the same time in real time. And every single patient visit that I have, I am learning something new, and it gives me another nuance as to what they're experiencing. And I'm very interested even in the ways that not just the way patients describe their symptoms, but also the things they're doing to try to remedy them and the things that help and don't help. And sometimes there's clues in that, whether it be a diet modification or acupuncture, people have really gone creative in trying different things. Some of them are maybe not so safe, and we have to be careful about, disseminating misinformation. But in some cases, people are really trying to get at like the 4 pillars of health, relaxation, sleep, nutrition, movement, because it is harmonizing things definitely helps. So I have to say, I learn a lot from the patients. It really does drive the research. And even just like a simple example of that would be, the anecdotes that were emerging of patients who felt better after vaccination. I mean, I think that, that's fascinating, because if, it does lead to potentially something related to immunity, immunological response as maybe driving it. And what we've seen when we've looked at that question a little more closely is, there's some patients who do report feeling better, and it's, remains to be determined if that's related to the vaccine or if it's tincture of time and it's just true and unrelated. There's patients who have absolutely no difference after the vaccine, and there's patients who felt like a COVID flashback, which is also interesting. Like they really get a flashback of their symptoms, and sometimes it's 1 day, but sometimes it's 2 weeks. And I think there's something to be learned there, and that's something we wouldn't have maybe grasped had we not been listening to the patients.
That's helpful. You spoke earlier about collaboration, and I'm wondering if you can elaborate on that. How do we facilitate collaboration across the different disciplines and pillars of biomedical research? So, for example, how can an organization like us, CADIF, contribute?
So I think things that definitely help foster collaboration are awareness first off. If you're not aware of what's going on, if you're not aware of who's doing what or what the resources that are available are, it's very hard to really develop collaborations. And, you know, simplistically, I mean, I can see sometimes there's people in the same building, you know, that aren't aware of things going on, you know, because one is in the lab and one is in the clinic. And so, you know, awareness, I think, is very key across disciplines. And I think that CADIS definitely helps with that, with the creation of webinars, and webinars that reach to different communities. So, you know, going really across the biomedical sphere, going into the general population as well, and maybe even into other disciplines altogether. Tied to awareness is networking, right? Having a good network. And that's not always obvious. You know, I'd say that you know, I spent, you know, 8 years at the NIH, and I had a really good network there. And then I moved to Montreal just a few years ago, and, you know, getting that network set up locally is not always obvious. And sometimes I think, you know, again, CADIS, through its range of scientists and of clinicians and of other members of the community, you know, can help, I think, foster networking. I also think that different funding initiatives where, you know, the agency actually tries to sort of match people together, that can also help. And with that, I think we also have to lose fear. And maybe here I'm speaking as someone who's a little bit earlier in their career, but I think sometimes fear can hinder fruitful collaborations. It could be fear of not having a mutually beneficial collaboration, or fear of not being successful, or fear of not being recognized, and therefore your time was not properly spent because we are evaluated by all sorts of metrics in our career. And so that ties in with time. Sometimes, you know, having a lack of time is not, it hinders collaborations, or because we have to think carefully of where we're going to use that very little time we have to dedicate to research. And so if there's more established infrastructures, if there's funding, and if maybe as a whole we focus more on recognizing and praising teamwork and collaboration as opposed to individual work. And, you know, if we really value that and we demonstrate that value, and people are rewarded for those sort of collaboration, that sort of spirit, I think we will have more collaboration. And if we have collaboration, the science advances so much faster, and patients can get care and new interventions so much faster.
Couldn't agree more. I think we can all say there's so much work to be done. So collaboration will be key for sure to tackle this topic area. I do want to make sure we get some time to address some of the audience questions. They are continuing to come in, and we do have some great questions. So we'll go ahead and jump to those right now. And just a reminder, if you'd like me to direct your questions specifically to one of our panelists, please let me know. I am noticing that our conversation is addressing some of the questions already coming in, so I'm happy to see that. So the first question that I'm going to pose here is if we can talk a bit more about rehabilitation for patients with long COVID, the role of rehabilitation staff, so our OTs and PTs, and if any best practice guidelines have been created. So I'm not sure if Dr. Chung, if you want to start. I know you mentioned earlier about some rehabilitation, or Dr. Grainer as well.
Yeah, so actually recently the Canadian Physiotherapy Association actually has put out guidelines for long COVID. And I can't show it, but I can certainly, you know, send you a link to that. So unlike usual sort of rehabilitation where we try to push the patient, you know, do a little bit more, even if it hurts, do a little bit more. With post-COVID condition, we're actually trying to stay under the threshold, as Jesse was mentioning, so that we actually don't want to push people to be above that. And it's a slow, they have to stick at a certain level for a long time before they can actually try to move forward a little bit. I think those guidelines are important because then community and academic sort of physiotherapists, occupational therapists, exercise specialists can actually use these guidelines to help their patients.
Thanks for that. Dr. Gerner, did you want to add?
Yeah, I'll just suggest that we use the term like patient or symptom titrated physical activity, right? So we want to titrate the physical activity to a level that does not flare their symptoms. And then gradually over time, that level of activity goes up. And so that's really like the cornerstone of what we talk about here. In terms of, I'm just getting a little bit of feedback. Are you guys hearing feedback on my end? Perfect. Okay. In the context of rehabilitation, I think it's important to talk about like resource limitations in the context of rehabilitation. That's certainly something that we've been challenged with here at the COVID clinic. And we are like relatively organized. Like there's clinics at multiple different hospitals around BC, and you know, all the physiotherapists are like meeting together to talk about all of the the guidelines and how they should be helping patients, but there's still an incredible lack of availability for occupational therapists, for physiotherapists, for physiatrists, for psychiatrists, for cognitive behavioral therapy. In terms of biopsychosocial, like each domain requires rehabilitation, right? And so the biological rehabilitation, there's dysfunctional breathing, the physiotherapists and respiratory therapists can do, especially in patients. There's actually evidence in patients that are admitted to the ICU that pulmonary rehabilitation can have beneficial outcomes for patients. There's psychiatric rehabilitation that talks about cognitive behavioral therapy and mindfulness and meditation-based practices, and then there's emotional or cognitive rehabilitation, which we're just sort of starting to really understand and grasp here in terms of how to move down that pathway. But it really does require a lot of handholding, because I think a lot of patients don't understand what their experience is, or where their symptoms are coming from, or even how to understand this idea of like multitasking and like fixed attention versus like other types of attention. I barely understand some of those concepts. So I really think there's a role for the resources to be in place for those providers to be made available for these patients, because otherwise, without early intervention, I do worry we're going to see a syndrome that, much like chronic fatigue, where you end up with a chronic illness that doesn't go away. Yeah.
A common question that I'm seeing in the chat right now is in regards to reinfection. So I'm wondering, do you think patients who get reinfected with SARS-CoV-2 or that get breakthrough, so post-vaccination COVID-19, are at risk for the post-COVID-19 condition?
I think that patients are certainly at risk for it, but I think that the incidence will be a lot lower than in the non-vaccinated population. I think that's at least what some of the preliminary evidence is suggesting.
Yeah, and I agree that if you are vaccinated, your chance of getting reinfected is way lower than if you are unvaccinated. And so if you are not infected, you won't get long COVID. You don't get long COVID condition unless you were infected. So that's one issue. There was a recent study that just came out this past week that was in the media about those who were infected, whether they were vaccinated or not, they still carry the same sort of viral load. And that's not too surprising. There's also another study that shows that maybe the viral load is a little bit less and they're a little bit less contagious. So that piece is still controversial. But what is not controversial is if you have been vaccinated, your chance of getting infected is much lower. And obviously, vaccination is only one piece to prevent long COVID. I think wearing masks in crowded indoor areas is still important. Just like, treating cardiovascular disease. It's not just treating your high blood pressure. You got to look at your cholesterol. You got to look at all the other factors, smoking and whatever. So in order to sort of, trying to get rid of this pandemic in Canada, we got to do all those pieces. It's not just one thing.
Absolutely.
I'll just add one more thing. There was one study published, I think it was the UK COVID symptom study app, where they actually were looking at patients in that specific cohort, right? The people that had been vaccinated and then still got infected with the virus. And they were suggesting that there's almost a 50% reduction in the incidence of, patients with more than 5 symptoms greater than 28 days after symptom onset. So there's some very encouraging early, potentially biased evidence out there to suggest that there's maybe hope for us that vaccinations will reduce the incidence of this.
So I'll squeeze in one more question as we're starting to wrap things up here. So given the immediate challenge of dealing with COVID-19 cases, is there a risk that long COVID becomes an afterthought and that is not given much attention by health systems? Any reflections on that?
I guess I'll start. When I was sort of in the early stages of setting up this clinic, I came across a paper that was written by Michael Porter. It was talking about, he's sort of a famous economist, but he talks about the hierarchy of needs in a sense, if you will. And so he separates the needs into certain categories, right? And he talks about the first thing that patients care about is whether they live or die, right? And then they care about chronic illness and longstanding illness. And then they care about, how much does their quality of life decline? And then for how long it stays down. So there's sort of this there's this great paper that talks about from a value-based healthcare standpoint, what are the things that we should be focusing on first and prioritizing. And I think it's absolutely right to focus on people not dying in the ICU and to focus on people getting vaccinated and to focus on the public health measures, because that's where the biggest bang for the buck definitely comes from. I think this is the next thing though, right? And it's not necessarily right to ignore the illness here. And yeah, I think that we need to be paying attention to this so that we don't run into the problem down the road with long-term sequelae.
Thanks for that. So we are wrapping things up. Before we go, I'd like to give each of the panelists the opportunity for a final word. So maybe we'll start with you, Dr. Falcone. In about 30 seconds, if people only remember one thing from this webinar, what would you like it to be?
Well, the post-COVID condition is complex. It requires a multidisciplinary team. We need to integrate clinical care with research, and collaboration helps accelerate science.
Great. Dr. Grainer, do you have a final message for health policymakers about what the system needs to deal with long COVID?
Yeah, I was thinking about this recently. There's an interesting study that was put out by the Veterans of Health in the States that was basically a bird's eye view of what are the increased incidents of all these ICD-9 type codes, what are the incidents of healthcare resource utilization in the States. And we see almost across the board, there's a massive increase in healthcare utilization. And I think that that's a concern for from a health economic standpoint for cost, right? All of these things have, billing codes attached to them, and there's fee codes attached to all of these things. Whether that's just more people being engaged in healthcare than previously, and we're catching diagnoses. There was a question I saw about cancer, whether we're just catching cancers because people are engaged or they're wrapped up in the healthcare industry. They have a physician that they're seeing regularly for these issues, and they're being worked up. There's potentially value to those things, right? And maybe there's cost savings down the road by catching a lot of these things early and managing the diabetes that was hiding underneath the surface that patients were not getting looked at. So there's really potential value there, but the real value, I think, from an economic standpoint really comes from making sure that people are able to get back to work and they get early intervention in the patient education and this rehabilitation piece. Because I think if you can intervene early in the illness course, I fundamentally believe you can impact the trajectory of the disease.
Great. And finally, Dr. Chung, in 30 seconds, are you optimistic for the future and why?
I am very optimistic about the future. This pandemic has its challenges, but it also has its silver linings. One is actually we are collaborating across the country with people that we would never have collaborated with. And I think the amount of science that has come out in the last year and a half is amazing. I'm talking about from Canada. And I'm optimistic for the patients as well, because we are getting new treatments. We are going to test treatments. I would encourage patients to participate in research studies and contribute to making new science. So that I think the science will spill over to other areas as well, not just long COVID.
It's reassuring. That brings us to the end of today's session. A big thank you to Dr. Chung, Dr. Grainer, and Dr. Falcone for their clear and forthright answers to some very difficult questions. Thanks to all of you for tuning in. We'll be sending out a short evaluation survey, so please take a moment to fill that out so we know what other topics you'd like us to cover. Check CADIF's website, cadif.ca, for information on other upcoming events. And lastly, just a quick plug for our 2021 CADIF Symposium. It's only 3 weeks away, so please register if you haven't yet. Until next time, continue to follow safety protocols to protect yourself, your loved ones, and your community. Thanks again, everyone.